how does clinical ethics differ from research ethics? What is the basic difference between clinical ethics and research ethics?
In research, you are trying to answer a question, trying to seek some answer to fill a knowledge gap. Though in both, of course, you'll have to bear in mind the beneficients, non-maleficients and all that. I think the objective differs.
Anybody else would like to add? Or
in research, you have a hypothesis which you want to prove or disprove. In clinical research, you are taking up the trials, drug trials, or about various treatment procedures for the patients.
Whose interest is primary in research ethics as compared to clinical ethics?
Research ethics, the investigator, like social scientists, and the medical persons, both can be interested.
And when it comes to clinical ethics, whose interest is the most?
I think it is basically the persons who are trained in medicine. Medical persons.
Not medical persons. It's the patient who is the center of everything that happens in clinical ethics.
Research ethics or clinical ethics as separate entities, they are all, one interlinked with the other, because the human subject is the primary concern. For its benefit, for human benefit, you are doing, whether you are trying a hypothesis, as she had said, or and to prove that hypothesis, you are undertaking that clinical research for the benefit of the patient. So it is that you cannot differentiate the two separate, it is a combination, or a area like you have the Venn diagram, you have the area where you have the human being in between.
Does anybody would like to?
Or is it like the research ethics deals with ethical considerations only for the mission of research, which is a short-term, time-specific program of proving or disproving, and clinical ethics would be having ethical considerations for routine practices on everyday basis between the health provider and the health service receiver on daily basis as to how to deal with the patients on routine in clinical practices. The moral and ethical considerations there.
You say that research ethics is something which goes only in relation to research, whereas clinical ethics is day-to-day practice of medicine. Anybody else would like to?
This is the dyad of relationship between recipient, so that means here the participant or the patient, and the person who's provider, which could be whether it is a clinician or it is a researcher. The relationship between them is something that is important. How to establish the relationship, whether it is in form of giving a service, or even if it is research, then also there is a service involved. The question is, a relationship of trust needs to be coming in, so that one could involve them in the, whether by providing them service, or it is involving in a study, so that the long-term, the immediate short-term and long-term implications could be understood and being brought into the whole ambit there.
In clinical ethics, there is a component of medical component is there. In research ethics, there is not a must. It's not a must that we should have a clinical component.
Clinical ethics is dealing with individual patients, and it can be little individualized. Whereas in research ethics, you have a protocol, you have to go by that protocol, and it's not generalizable.
Anybody from this side?
Clinical ethics, benefit for the patient is more important, while the risk also has to be reduced. But in research, we have to first think of reducing the risk, minimum risk to the participant, and whatever benefits can, just reversing that.
When we talk about clinical ethics, there are 4 different actors into play. You have the patient who is the center of our whole action and activity. Then you have the medical professional who has to have an input. Then you have to have a family, which is very important. We are not isolating a person as a single entity. We live in families, we live in societies. So family has a bearing on what happens. In a research, family need not come in, community need not come in. It is just the individual who comes and gets discussed about. And not only that, you have a third party in clinical research. somebody has to pay for treatment, whether it's a government, whether it's a ESI scheme, whether it's health insurance, somebody has to pay. So all these factors get involved when we are dealing with the patient. Now when we look at the principalism, which is the major way ethics deals with, we have different principles that are applied. When we talk about the first two principles, do not harm the patient, do the best for the patient, it's mainly in relation to the doctor or the medical team. That is our two principles of medical ethics that we talk about. Do not harm the patient, do the best for your patients, non-malfeasance and beneficence. Then we have the patient where the principle of autonomy applies. Okay, he decides what is best for him and what is good for him. Then we have the fourth principle, that is the principle of justice, which encompasses all these things. That is the third party, the family and the patient, that is, and the doctor, which has justice for the care of the patient. Now when we look at the different types of this thing, primary ethics research interest is that of the researcher. Patient is not bothered. Patient wants to get better. He is not bothered whether A treatment is better than B treatment or C treatment is better than A treatment. He only wants to get well. Whereas, and the doctor's main aim in treating the patient is also to make the patient better. But once you have a researcher, the main interest is the research question. Okay. And the second thing is, patient does not have a primary stake in research ethics. Okay. And patients in research ethics need an external agency to protect and monitor. That is why you have IRBs. Whereas in clinical ethics, it is 1:1, and if there is anything, the patient will have to go to medical negligence, go to court. And lastly, money plays a major important in clinical ethics. Finances are important. In research ethics, the funding organization has to find the money. Whereas in clinical ethics, it is the family, it is the patient who needs to find the money. So these are the major differences that we see in research ethics and clinical ethics. So clinical ethics sometimes turns out to be situational ethics. You go to a particular situation, you weigh the pros and cons of that situation and decide what is the best thing to do. Okay. And in clinical ethics, there are no black and white areas. There is no such thing as this is the only thing that has to be done, this is the thing that should not be done. Depending upon the situation, we try to find solutions. And we will talk about how to make these decisions later in the study as we go along. Now, I am supposed to take today's session on risk and benefit. When you talk about risk and benefit, I think Dr. Nandini would have talked about in research ethics. In clinical ethics, it takes off a little different meaning. When you say judgments about the most suitable medications are a balance between probability of benefit and risk to the patient. It is a probabilistic way of deciding. Now, when we look at the definitions that we have, that there may be a future harm may occur. Harm is a setback to the patient's interests, particularly to life, health and welfare. Okay, and usually the risk is arbitrarily expressed as small risk, high risk, and both are ambiguous. And both are dependent on chance or probability of experiencing a harm and severity of the magnitude of the harm that is there. So you both have the chance and also as the severity of the harm that can take place. Now there are certain terms that are used in risk when you talk about clinical topics. One is risk assessment, that is we analyze and evaluate the probability of a negative outcome, especially that harm that can occur. Then you have risk identification, where you go and locate an hazard that may happen because of intervention. And there is a risk estimation which determines the probability of harm from the hazard. And you characterize the risk by assessing the management. Then you have risk perception, how people perceive what is risky to them. Now there is something called uncertainty. You know, everything in life is uncertain because we cannot be predictable. Knowledge is improper or because there is improper evidence. And uncertainty may be due to other factors. It may be by the way they use things, social and cultural factors. Classical example is protection offered by condom and HIV. You know, the quality of condom may be good, okay, but the way the person uses condom may give rise to failure. So you cannot say, you know, the risk of using condoms and getting infected is negligible, because there are so many other factors that come into play when we are talking about the risk. Okay. Now here I have one case. You know, blood transfusions are common in this. Blood transfusions carry certain amount of risk. The risk may be for two reasons. One is you can get transmitted diseases through the blood, and the second thing is the blood itself, there can be reactions to blood transfusion. Here Lalita, a 30-year-old woman who comes with tiredness and is found to have a hemoglobin of 5 grams. Normally anything above 10 is normal, anything below 10 is considered as anemic. Doctor orders packed cell transfusion. Blood bank releases a unit of packed cell to be transfused after testing the blood with mandated tests. Is there a risk for Mrs. Lalita? What risk she'll have?
Transfusion reactions.
Okay, she'll have transfusion reactions. Okay, then no. Usually, when you test the blood is tested for 5 diseases. Pardon? Window period. Okay. And the risk is minor. Anything else? Okay, she can have transfusion reaction, cardiac failure. You talked about infectious diseases. Can enter any other infectious disease? You check for hepatitis B, malaria, syphilis, and in Northeast you check for C mandatorily, and you check for HIV. The group type will be done regularly. Only then the blood will be released, no? See, there are another 20 other infections which can be transmitted by blood.
Myasthenia gravis.
No, myasthenia gravis, no. You can have toxoplasma, you can have other viruses like Ebola virus, Marburg virus. You can get the latest Creutzfeldt-Jacobs disease, which is a prion disease which will affect the brain, and person may become lose their brain, they can become demented and develop chronic neurological disease. Though we do the blood test and you say that it is mandatorily passed through the test, there is some risk of getting infected. Okay. Now we have a second case. Mrs. Begum, she comes to the hospital at 11 p.m. in the night, swelling of leg, breathlessness of 5 days duration, complaints of heavy menstrual bleeding. Examination, she is found to be in shock and is having cardiac failure, severe anemia. Hemoglobin is found to be 2.1 gram. The doctor orders for an urgent transfusion. One of the patient's attendees donates blood. Doctor transfuses the blood. Is it safe to transfuse Begum with the blood which they have received in the emergency?
Without testing.
Without testing. But
Going to the primary screening procedures.
it's an emergency. Here you have a patient who is dying. 2 grams hemoglobin, who is breathless.
No, but have to be group, cross-match.
Okay, they have group and cross match, but they have no time to do all the other tests. Group and cross match is basic. Without that, nobody will transfuse blood. Pardon?
It's not safe. But this relative must be suffering from some other disease. So till the mandatory tests are done, his blood cannot be cut.
No, but this is an emergency. You cannot wait, no?
Then can give the blood.
Pardon?
The blood bank give the blood.
Huh.
This blood can be donated to the blood bank.
No, you are not understanding the point that I am trying to raise. Here is an emergency. See, it is all right if you have a big place. But if you are working in a small place and you are only the doctor and you have an emergency where you have a patient who is dying because of anemia and there is somebody who donates the blood, are you justified in giving that blood without testing?
Yes.
Pardon?
Elicit history from the donor.
Okay.
On the strength of it, since you have nothing else to do,
Yes.
you are in a small place,
Okay.
no other blood available.
So, the next question that I want to take is it permissible to take a risk to save a life?
Yes.
Always? Okay. Little more, doctor obtains a consent absolving him and the hospital for giving untested blood. Can it be defended legally? See, in dire circumstances, it can be justified that they are doing something because of the best interests of the patient. But if that patient tomorrow gets better and starts suing you in the court, you cannot defend it easily. This is the point that I want to say, because it very often happens, patients have consent forms are written. As we talk about consent, we will talk about more, where patients just write and say, no, I am give permission to do whatever you want with me. A blanket consent form is taken. So when the person is going to be harmed, this consent does not legally be valid for the person. Okay. Now next we have another one patient. Lucy has been brought at midnight. She has delivered. She has had torrential bleeding, goes into shock. Husband donates the blood and blood is transfused to Lucy without mandatory testing. Is it safe for Lucy? Usually when you do an antenatal test nowadays, the antenatal mothers are tested for syphilis. They are also tested for HIV infection, and in some centers they are also tested for hepatitis B. And she is receiving blood from the husband. And if at all she got these infections, it will be from her husband. So will it not be safe? But one other thing you must remember, you can never trust the husband what he was doing in the last 3 months. No, I'm trying to bring out to it's not just patient and doctor, it's a whole gamut. Because if you look at some of the practices that happens is 8th month the girl will be sent to the mother's house and this man goes out and has fun. So what I am trying to put is just, it is never a straightforward thing, but you have to take into consideration all these things. So when you talk about risk, it can range from hypothetical risk that we know which is possible, like in the first case we know what the possibilities are, biologically plausible because we know viruses can be transmitted, bacteria can be transmitted without being checked, and there is level of risk for these infections are not known in the general population because they are very, very rare disease. Okay. And we know clearly we can identify that if the untested blood is given, there is a chance that the person may get infected. And the risk to an individual always remains a probability. It's not absolute. Okay, the risk of getting HIV infection through blood transfusion is about, if it is there, this thing in a general population is about 3%. Okay, so this type of thing happens, and so it is very difficult for us to quantify and say this is the risk, this is what we can do for you. When you talk about the purpose of communicating risk is to provide the individual sufficient information to make choices about the consequence of the risk and assist in deciding which action or actions, if there are any, to be taken. So the risk communication is mainly for the patient's autonomy. He needs to know what is the right thing to do, so he has to make a decision. And it is, remember, it is a dynamic process. It is not something which is passive. There is interaction taking place. Doctor may think that something may be very trivial risk, but for the patient it may be a great risk that takes place. And risk is unknown, communication becomes very, very difficult. So usually when you talk about risk, certainty of risk is obtained from evidence base. We know what is suppose you give penicillin injection, there is 1 in 10,000 chance of developing anaphylactic shock. So we know the risk and the probability of the risk. Then we also know whether the risk is high or low. In certain communities, the risk may be low for this. And the risk of administering penicillin, they can have an anaphylactic shock. The ultimate end of anaphylactic shock is death. Okay, that does not mean that every patient whom I am going to give penicillin, I will say, I will give a penicillin injection, there is a chance that 1 in 10,000 people may die. Okay, and if you want to take that risk, I will give you the injection. Nobody talks to that way in practice. Okay, though we know that there is a risk involved in this type of treatment. And whenever we talk about risk, the process of risk, we divide it into 3 different ways. One is anticipatory. We do not know what the risk is. We are trying to define what the risk is and find out. Then we communicate this risk to the patient, and once you communicate the risk to the patient, you get a feedback from the patient which becomes a learning experience for you. Next time when we talk about it, you try to modify it to suit what is to be said. This is known as the framing effect. Have you heard of this term, framing effect? The way you ask questions is the way a person will respond. Like for example, if I say the 50% chance of death, people will refuse. But if I say the same thing, the 50% chance of survival, people will think that is something good. Okay, this is known as a framing effect. So the way a doctor talks to the patient makes the difference, and that is why you have some good doctors and some bad doctors. Both of them will convey the same information, but the way they convey the information makes all the difference between patient and doctor management. Now, during the anticipatory phase, we know that certain drug is going to produce a side effect, but we do not know how much it is. We collect information on it. Like for example, if you take the latest controversy that we have in medicine is using of a drug for diabetes called rosiglitazone, and when it was brought about, it was talked about as the best drug to bring down the sugar levels fast, and clinically it is very effective. 5 years down the line, suddenly there are studies which show it can produce heart attacks. Okay. So, and this was known long before, because it was shown that in the rats it produces atherosclerosis, thereby increases the chance of developing heart attacks, before the drug was released into the market. And now there is a huge hue and cry about rosiglitazone, saying it should be banned because it can produce heart attacks. Okay. So, this is the phase of anticipation. We do not know what is right, what is wrong, and how effective this thing goes on. Now, this is another issue that we need to tell. If we know that a drug is likely to cause, or there is a risk for this procedure, should we tell that about it even before we get confirmed about the risk that can happen? This happens especially with surgeons. See, surgeons go through a learning skill. You know, there is a phase when you make mistakes, and there is a phase when you become a good surgeon. Okay. Also, a surgeon who just begins to do a particular kind of operation is likely to have complications than a surgeon who has done hundreds of those operations. It is just a skill, but nobody goes and asks a surgeon, how many surgeries have you done, what is your result? Nobody goes and asks. Okay. And no surgeon will also tell, no, this is my first case that I am doing. Okay. So, these are issues that raise in clinical ethics when we communicate to the patients. How do we say these things? Okay. Perceiving the risk is also something very, very thing. We think just because we talk about it, like a framing effect that I talked about later, they will make rational choices. Even when risks are perceived, people will not make rational choices. Example is smoking. Everybody knows smoking is injurious to health. There is enough and more propaganda about smoking, yet patients as well as doctors smoke. It is not that they do not know, because you think that you may be free from it and you may not get cancer of the lung, or you may not develop chronic bronchitis. So, perception is something that you cannot do this. Some people have notions which are ingrained, which cannot be shaken off very easily. Classical example is in diabetes. Rice eaters will say, oh, if we eat wheat, our sugars will come down. And if you know scientifically, the amount of calories that is there in the wheat and the rice are the same. Okay. But this perception is there in the general population. So, you tell them, don't worry about rice, eat wheat, eat little rice so that you will be comfortable, enjoy it. No, 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 sugars will go up. You know, and this happens even among doctors. You know, you have learned in nutrition, they are both the same. But when it comes to practice, you are not willing to accept it. Okay. And this is what happens when you talk about perception. Any questions about risk?
In an informed consent document, is it okay to say unknown risk without specifying anything? Would it be ethical to say that?
No, I don't think it's ethical to say unknown risk. Unknown risk can be death also, no?
Yes.
No. When you are talking about unknown, this thing is the risk may come about. See, you may discover an adverse reaction as part of the research, but that is not as unknown risk. That is adverse reaction. Okay, when you mention in a research document, informed consent means you will mention what are the risks that are likely to go under with this procedure. Because when you say there may be unknown risks, that's a blanket statement to protect yourself from anything that can happen.
They say foreseeable risk should be told.
Foreseeable risk is different than unknown risk.
No, unknown is not there.
Foreseeable, yes, I agree with you. We can't.
Excuse me, sir. So what is this, when we see on most of the medicines marketed, it says no known risk, no known complications, no known adverse effects.
Yeah.
So meaning,
so far we do not know about it.
so far we don't know about it, but then it is still being marketed.
Yeah, it's being marketed because I do not know when, you see, when drug trials go in, drug trials go into 4 phases of development. The first phase is when you do it on healthy volunteers with particular dosage to see whether there are toxic effects on the healthy volunteers. If there is, and to study the pharmacology, what is the excretion, metabolism, and at that time you find there is nothing wrong with it, then you go into stage 2. Stage 2 is people who have got real sickness with the serious disease. You give them the drug and see whether it is effective. Once that is effective, then you go to stage 3 where you do a randomized control trial, where you have a group of patients who have the disease. Half of them will get the active drug, half of them will not get the active drug. Okay, the Indian Drugs Pharmaceutical Act requires only 20 volunteers for testing. In the second stage of drug, depending on whether it has been marketed abroad or here, you require 100 to 500 volunteers. In the stage, the randomized control trial, depending upon what is the difference they want, you may do studies on 1000 or 2000 patients. Okay. The fourth stage of the drug trial is what is known as post-marketing surveillance. The drug is released into the market and there are thousands of people using the drug, and as the people use the drug, there are side effects developing, and these side effects have to be reported to the drugs controller, and when the drugs controller finds that it is an adverse reaction, the drug is modified, there is warnings issued, or it may be removed from the market. This is how the drug goes through the process. Till that time they may not know whether there is a positive effect or what are the adverse effects that take place.
Okay, so that means to say that at any point of time, any drug cannot be ruled out to have 100% no side effects, right?
That is something in medicine. There is nothing 100%
we
in
cannot
medicine.
say that, right?
Yeah.
So in the same way, when she just talked about the informed consent to be given with this clause attached, that with the experimental research is made, we know this much, that it is not going to have an adverse effect in this domain. Yeah. But besides that, the adverse effects are unknown.
That becomes part of the study. It becomes part of the study. You are not telling, you know you are entering into the study. These are the foreseeable risks. This is the risk that you have. As we progress into the study, you may have something which is not foreseeable. That doesn't become a part. So once you say it is a foreseeable risk and explain it, then the onus for the care for the patient or whatever it is acceptable. As part of the study, if you find something new as developed, that is not a risk. So the subsequent studies will modify it and take it in. Now when we come to benefits, things that positively contribute to the welfare of the patient, that is risk reduction, cost avoidance, positive value, not probabilistic, are part of benefit. And usually principle of beneficence takes over principle of non-maleficence, something we have to do good to the patient. And usually positive beneficence is what is known as agents that provide benefit. Utility is the balance of risk and benefits to produce overall good result. And when you talk about benefit in the research context, something of positive value which is related or welfare of a person. This is the Belmont definition of beneficence or benefit. Okay. How do we judge what is beneficial? Okay. We usually go by evidence base. Okay. And now this evidence base that we have to judge something is beneficial may not be always be true. It depends on the type of study that is conducted. It depends on the biases that are included in the study. So the evidence always need not be true. Sometimes people use on practical experience, especially the surgeons. Okay. They may have one way of doing a procedure. The fellow may tie the artery first or the vein first, and in his practical experience, that would be the best way to approach a problem. Okay, and that will produce benefit to the patient. Now you have a 65-year-old man, Mr. Raju, disseminated malignancy. He has been admitted with the diagnosis of sepsis. Blood culture shows that organism is sensitive to a new antibiotic called Tavaran. Cost of therapy is 8,700 rupees per day. Will you prescribe it? Here is another problem. An agriculture laborer, he has a cobra bite. There is no money in the family. Patient needs a ventilator.
I think it's necessary to take the patient and the family into confidence, and if this drug, Tevron, was the only one that was, the organism was sensitive to Tevron, that was the only drug, we'll have to tell him that. If there were inexpensive alternatives, we'll have to explain all that and tell him. So that's my take. Ventilator, positive, there is no doubt about that. I think we'll have to, cost should not stand in the way.
This patient even otherwise is not going to serve his, like if you're looking from a clinician point of view and the patient's family, the family is not going to be supported much by this patient because of the nature of the disease he is suffering from. His longevity is very less, whereas an agricultural laborer might serve his family longer than what he is going to do. So probably that comes also in the view that in this case, you will have to take the family's opinion before we start the drug and not there.
Okay, since you brought up that type of issue, I have got one more case. Okay. He developed, Don has multi-infarct dementia. He developed respiratory failure. He is on ventilator for 20 days. There is no improvement in clinical status. Treating physician wants to discontinue the ventilator. Relatives request the ventilator to be continued, but still the son returns from Australia. Sentiments.
We have to respect this. We have to continue.
What if you have, this patient is there in the ventilator, you have only one ventilator, and you get the other Suresh who is bitten by the snake bite and he comes.
When the situation changes.
But we have to give first come first please.
No. Situation is important.
These are things that happens about, and that brings us to a concept known as futility. When do you say a procedure that is necessary, though it may be beneficial, is futile? This is a major issue when you are talking about beneficence. When do you say that what you are doing is futile? There are no definitions, no criteria that have been set forward, and there will be procedures that cannot be performed because a patient's biological condition is bad. Procedures do not bring intended effect. Burden, harm and costs will outweigh the benefits. And the people have defined when to say that intervention is going to be futile. There is no chance that the intervention will work. Okay. And there is some people have tried to use statistics. One of them is to use 13% or lower chance of success. And the third one is 100 cases you find that the patient has not improved, then you know that treatment is futile. Okay. Now if you apply this criteria, the third case is totally futile. He is multi-infarct dementia, he is on a ventilator for 20 days, there is no improvement. Okay. Whereas the second case, where there is a person with a snake bite who is recovering from, you know that if the person is ventilated for 48 hours or 72 hours, he will be perfectly all right. So the treatment is very beneficial to the patient. So, and when you talk about the first case, that is where the ambiguity comes about. We know that he is in terminal stages of thing. We do not know treating this person with an antibiotic is going to make his life comfortable or prolong his life. And we do not know how much the family can afford. See, the way you frame the question to the family is also important, and how we communicate the risk or benefit to the patient and their relatives. Okay. Next point that we have to this is, can a patient demand inappropriate treatment? Yes or no? No. Doctors have a right to refuse inappropriate treatment. Okay, we have a right to refuse inappropriate treatment. What you feel is not necessary, and patient cannot hold you responsible for negligence or for not carrying out the treatment. Okay, this is a latest case that happened recently. Rathod has passed the written examination for police department. Department requires candidates to be 170 centimeters tall. He is 168 centimeters tall. So he asked the plastic surgeon in the town to increase his height by doing messing up with his cranium. I don't know what that surgery was, so that his height becomes 170 centimeters, and he can be. Can you do that? See, now it again comes to question is, what do we do with cosmetic surgery that goes on? If there is a nobody is a plastic surgeon here. No. Because how do we justify changing the shape of one person's nose? There is no medical indication for it. These are things that happen in practice that we need to think about and see what is the right way to go. Remember, plastic cosmetic surgery is a major money earner for doctors. Okay, and if we talk to people who do that, they will justify anything under the sun because it brings about money. And as people who are involved in medical practice, we need to question ourselves whether what we are doing is right or wrong. So benefits can be medical benefits, they can be psychological benefits, they can be sociological benefits. You can apply these benefits to an extremity and also cause harm. Classical example is eugenics. You want a good society, so you use all technology to produce good society. In the process, you dehumanize a person. Okay. So what I am trying to stress is benefits and all are relative terms that need to be weighed, balanced, and the best be taken for patients. Okay. Now when we are talking about this thing, we also talk about trust. Okay. What do we mean by trust? And one of the suggestion is emerges from identification of a need that cannot be met without assistance of another and some assessment of the risk involved in relying on the other to meet this needs. Trust is a willing dependency on another's action, but is limited to the area of need and is subject to overt and covert testing. Outcome of evaluation between expectations of the trusted persons and the actions are important. So trust is something that grows over time between doctor and patients, and usually trust is tested. Indirectly, patients test you whether you are worthy of their trust. And remember, two metaphors are used in describing trust. One is going to a place, journeying. When you have to begin a journey, you plan the journey. Okay, there are so many things that happen in the journey that you have to take into account. Similarly, when you are building a house or a building, you need to put a foundation, you need to have a plan. Similarly, trust grows over time when you talk about truth, openness, sharing, respect, views of others, tolerance, rights of others to make decision, autonomy, doing the best for others. And it does not mean that because patient trusts you that everything will go fine. There can be difficulties with it. And remember, trust is not easy to establish and it is very easy to lose. It has been said trust can come on foot, goes back on horseback. See, what I mean is, to build trust it takes time. To lose trust is just one word or one action. Any questions?
Sir, regarding the case of 65-year-old man with malignancy.
Yeah.
Why I gave that answer? I had gone through a case in the Kerala consumer protection this thing. A patient was admitted to the hospital with a thorn prick or something. An X-ray was taken. Foreign body was not identified. But he explored, the surgeon explored. He couldn't find anything. Was put on IV antibiotics, observed. The infection didn't subside. Second re-exploration done, couldn't get. When the infection became worse, he was transferred to another hospital. Another surgeon did the same thing, but he could find it. Finally, the case went to the Consumer Protection Court. And during the trial, these advocates used to keep on irritating the doctor. The doctor's mood went back. The advocate asked him, could it be seen in an X-ray? He said, may not be always if it is a vegetable particle or something. You cannot see. Then he kept on asking, what can you do to find that? So in a satirical way or something like that, doctor said, then you can do an MRI for that. Like nobody does an MRI to find a foreign. At that point, the judge intervened. Can it be found in an MRI, doctor? Then he was in trouble. He said, yeah, it could be found, but who is going to take an MRI? It's so expensive.
No.
So the judge asked, who are you to decide the expense? Did you give that option to your patient? No, I didn't give. Then he had to pay the compensation.
No. See, whenever we talk about this thing, Consumer Protection Act, the first point that you had to, whoever was the opposition lawyer, who was supporting and defending him, did not put this point. The point that should ask is it a standard practice to do an MRI to find this thing?
But since he couldn't find it for 2 times and
no. See, the point is like this. If I do not know about this case. I am talking it from looking at it from a point of person who has been teaching medical ethics. Our first question is it a standard practice to do an MRI to find foreign bodies? The answer is no. Okay. Now the second question is, if even you are so sure that there is a foreign body in the body and you have done 2 explorations, can you do something more to find out whether the foreign body is accessible or not? If the answer is you could do an more this thing MRI or something can be done and you have not done it, then it is breach of standard of care. Okay. And this is the point that we have to this. Unfortunately, what happens is people don't look at the point of view of the law. They only just look at the readings, the first line and the last line. He left this thing, he did this and he was punished like this. They don't see in between what happens, whether it was the standard practice which was breached or not breached. If he says it's a standard practice that was breached, then you will be fined for it. If this person would have said, I mean, if he had said no, we could have done an MRI, but it's not a standard practice that we do for this. But if there was a surely 100% sure that there was a foreign body, he could not find it in exploration, then he has a business to do an MRI and find out. The number of cases that succeed in the court is just about 5 to 10%. 90% of the cases get dismissed. But it's the harassment to the doctors that goes on with the case.
Now we know individually what constitute a risk and benefits also. But is there any schematic way or some way to talk about which one is more in favor of the risk or in favor of the benefits? Is there any way to schematically or something of that sort?
No, it depends on the situation. See, like for example, we know that
just a general guideline, not depending on
I am just talking about the general guidelines only. Like for example, treatment of hypertension we know is good. It is necessary because it protects life. Drugs used for treatment of hypertension have side effects. All the drugs that are used for hypertension produce side effects. So we try to balance the risks with the side effects depending upon the patient. Okay, like for example, if the person is older person, has got prostatic hypertrophy, you will go to alpha blockers for controlling his hypertension. If there is a young person who is recently married, you will not put him on beta blockers because it can produce impotence. Okay, so you always mix and see what is the best possible thing that you can give for the patient. There cannot be a universal law saying this is the risk, this is the benefit. If the risk is this much, you will not do it. If the benefit is this much, you will not do it. There are, like for example, aneurysmal surgery. There is always a chance, 30% chance the patient will die on the table. Okay, that doesn't mean that you will not operate on aneurysms. Okay. Okay.